You all know, All India Difficult Airway Association has been author for IDA consensus guideline for airway management in ward during COVID-19. Is one of the authors for difficult airway guidelines in 2016. He's been winner. He has got many awards. So I think this is enough Dr. Pitch, right? I'll introduce everyone. Thank you.
Good one. It's always a pleasure to be here at GSACON. And thank you, Team Nazari, Dr. Bhausar sir, Dr. Atul for giving me an opportunity to speak on practical tips optimizing LungMechanics with Anaesthesia Workstation. Why we need to discuss this topic? Why we need to learn the practical tips of optimizing LungMechanics? Just look at videos. All the patients, this red part, you are looking at this, these are atelectasis. This bright structure is a normal lung. So all the patients under general anesthesia develop atelectasis, that is for sure. And the amount of atelectasis is depend on how high FiO2 you are using and how long you are using high FiO2. And another thing, the atelectasis development, the rate is from 4 to 21% of the lung volume. If you look at this video, almost 25% of lung is not ventilated. That is one point. Another point, with the conventional ventilation, even a couple of minutes of ventilation can lead to ventilator-induced lung injury. These 2 points, these 2 things needs a change in the ventilatory pattern. So we need to change our pattern. We need to reach from atelectatic abnormal lung to change it to the more physiological lung. And that is where optimization is required. So don't make things worse with your ventilator setting. How you manage the lung intraoperative period that affects the postoperative outcome. So that can be done by changing your Anaesthesia Workstation settings. So volume control ventilation, pressure control ventilation, and peak, these are must. All of your machines should have these 3 things. And if you are having pressure support ventilation, that's desirable. But mandatory ventilation technique should have VCV, PCV, and pressure support. So we discussed that there is a belief, there is atelectasis. So we need to take a measure to prevent atelectasis formation. We need to take a measure to open atelectasis. And third, we need to prevent ventilator-induced lung injury. So let's discuss it. What are measures we need to take to prevent atelectasis formation? Always induce a patient in a head-up position, which increases the FRC and reduces the chances of atelectasis. And when you are inducing a patient, keep the APL valve closed at 10. Increase the flow to 15 to 80 liters, highest possible, and then an optimal mass fitting will deliver 8 to 10 CPAP. So then, by keeping the CPAP continuous positive air pressure, which prevents the alveolar collapse. So important thing, head-up position and CPAP. And if you are in a CPAP more on your machine, you can deliver CPAP by the optimal mass fitting. So now coming to this low pressure is required to prevent atelectasis formation. 8 to 10 pressure is required to prevent atelectasis formation. But what about to open atelectasis? To open atelectatic area, once it's there, it requires high pressure. And that can be done by lung recruitment. So recruitment is a technique, is a process, is a mechanism to open atelectatic area which requires high pressure. So when we are talking about the recruitment, means we are not preventing it to atelectasis, but we are opening the atelectasis. So conventional ventilation, either volume control or pressure control with the 12 to 14 frequency, tidal of 10 mmHg or pressure 60 to 22, will not open any atelectatic area. So if you are ventilating with this setting, means atelectasis will be there, you are not opening it. So the literature discusses the various techniques of recruitment. Vital capacity maneuver, peak, vital capacity maneuver followed by peak, step by step increasing the inspiratory pressure and peak. So we'll discuss the first 3 because of time and I'm not going to focus on all 5. So what is vital capacity maneuver? So maintain sustained pressure of 40 centimeter of H2O with 8 to 15 seconds. This will open all the atelectatic area. So it's a high pressure of 40 and it will be done in a parallel state. So if you are delivering 30, still atelectasis will be there. It reduces the atelectasis, but atelectasis will be there. If you are doing with the 40 pressure, look at the lung, completely open lung. So how to do it in a clinical practice? So manually you can open the atelectasis, recruit the lung, keep the APL valve closed at 40, change the ventilator setting to manual one, keep the APL valve closed at 40, keep the FIO to 40, increase the flow to 50 liters per minute. These will gradually generate the pressure in the lung, reaches up to 40, and once it, look at the graph, once it reaches the 40, wait for 8 to 15 seconds, this will overcome. This will recruit the lung completely. Look at this. I'm recruiting the lung with the 40% FiO2, with the 50 liters per minute flow, and keeping the APL valve at 40, and look at the lung, how lung is expanding. No atelectasis. This is how you should open the atelectatic area. This is one way, by manual one. Another is with the pressure control ventilation. What you should do, change the mode to the pressure control one, then change the I ratio to 1:1, decrease the frequency to 4, keep the FiO to 40, and increase the area pressure to 40. Now what happens? When you are changing the frequency to 4, so it means that 15 seconds of break. Now we are changing I ratio to 1:1. Means from 15 half means 7.5 will be infinity time and 7.5 will be extremity time. And you have set your area pressure as 40. So for 7.5 seconds, 40 centimeter of H2O pressure will be delivered. That will recruit the lung completely. So this is how another way to recruit the lung. Now look at this. This is real time video, 7.5 second video, and this red color are atelectatic area. Look at how it's recruited. Completely open lung. This is how you should recruit the lung. So, and few of the machines are having preset mode to deliver a vital capacity network. So, this is one of the machines from the GP where you can select the procedure, then go to the vital capacity. You can set the delivered pressure and set the time of recruitment. Okay, so 40 pressure will set and 10 seconds is set to recruit the lung. So another way is PEEP. PEEP is there to prevent atelectasis, not to open atelectasis. And many times, if you are delivering the PEEP in presence of atelectasis, it deteriorates the gas reception. How? Suppose this is that one is normal alveoli, another is atelectatic alveoli. Now if you are applying PEEP, so normal alveoli get expanded, which compress the underlying vessel, will divert the flow to the atelectatic area, leads to ventilation perfusion mismatch. So if you want to apply PEEP, the role of the PEEP is there for prevention, not to reopen the atelectatic area. So another limitation of PEEP is a microscopic image of the alveoli. If you are delivering the PEEP, it opens the atelectatic area, but once you withdraw the PEEP, atelectasis reappears immediately. Look at this. As I am increasing the pressure from 4 to 8 to 12, this alveoli is getting open. But once I start withdrawing it, atelectasis reappears immediately. Look, now withdrawing the PEEP. So it's getting collapsed. So, where to deliver PEEP? So if you want to deliver PEEP prevents the atelectasis formation. So PEEP to be delivered during the pre-oxygenation. That prevents the atelectasis formation. It should be continued throughout the procedure, and you should extubate the patient over the CPAP. So CPAP from the pre-oxygenation throughout the procedure and at the time of extubation. So keeping the lung open throughout the surgery, that's called open lung strategy. So another method to recruit the lung. So once you open the lung with the vital capacity network, to prevent further atelectasis, it should be followed by PEEP. So vital capacity maneuver should be followed by PEEP. That's the best way out. So you don't have to recruit the lung intermittently. Otherwise, you have to recruit the lung intermittently. So when you are recruiting the lung recruitment should be done with the 40% FiO2, not with the 100% FiO2. So if you are recruiting the lung with the 100% FiO2, once you withdraw the vital capacity maneuver, atelectasis reappears immediately because of absorption of oxygen. It's called absorption atelectasis. So this is lung fully recruited with the 40, but with the 100%. And when we are withdrawing it, look, atelectasis are reappearing. So this is the comparison of recruited lung and non-recruited lung. We should have clear this type of lung in an intraoperative period, not with the atelectatic lung. This can lead to postoperative pulmonary complications. So recruitment should be used in all patients under general anesthesia until and unless contamination. And we should have tailor-made approach for each patient for recruiting the lung. So again coming to the conventional ventilation, whether it's volume control or pressure control, both see the difference between ventilating the patient in the ICU and in OR. In OR, most of the cases we are having normal lung, and in the ICU, in most of the cases we are having diseased lung. The chances of having ventilator-induced lung injury is more common in normal lung compared to the diseased lung. And conventional ventilation, if you are not taking proper measure, can lead to ventilator-induced lung injury. Now what is wheeling? We are talking about wheeling. What is it? So, we think that there is an alveolar opening and alveolar collapse. Usually, there will be a ductal opening and ductal collapse. There is hardly alveolus, there is little bit of change in size and shape. They tend to retain its size and shape. Look at this. This alveoli is retaining its size and shape. There will be an alveolar opening and ductal opening and ductal collapse. And this is the normal microscopic image of the alveoli. There is a minimum change in the alveolar size and shape. It tends to retain its size and shape. But what happens in the wheeling? There is a lack of surfactant. The surfactant gets lost into the airway. That makes the alveolar instability. And this injured alveoli is not able to retain the gases for the gas section and lead to compromised gas section. And if you look at the microscopic image, there will be a cyclical opening and collapse of the injured alveoli. This is injured alveoli. It's opening with the pressure, collapse with that during the expiration. And if you can compare this both the images. One is normal, where alveoli tend to maintain its size and shape, while in wheeling, there is a cyclical opening and collapse. So we need to prevent the wheeling. That can be done by lung protective ventilation in intraoperative period. Now what is lung protective ventilation? You need to keep the tidal volume 6 ml per kg. Keep the high keep 7 to 10 centimeter of H2O. You can keep the I ratio 1:2 or 1:1 if your airway pressure is going down. Any mode is fine, volume control ventilation or pressure control ventilation. And keep the FiO2 as low as 30 to 40%. And seal the airway pressure less than 30. That is lung protective ventilation. So there is another way of ventilating a drum, that is a driving force concept or driving pressure concept. So driving pressure is the Plato pressure minus P. So look at this here, Plato pressure is 20, P is 10, so my driving force is less than 30, that is normal. So always ventilate the patient with the driving force less than 30. So open and second we have discussed. So keep the lung open. Start the delivering the CPAP from pre-oxygenation and continue the CPAP throughout the anesthesia and extubate over the CPAP by during the extubation, change the patient to the manual spontaneous mode, keep the APL valve closed at 10, increase the flow, keep the tube connected with the circuit that will deliver the 10 CPAP and extubate with the connected circuit. So that is how you can keep the lung open throughout the procedure. That's called open lung strategy. So to summarize, always take measure to prevent atelectasis by delivering a CPAP during pre-oxygenation. Measure to open atelectasis, always recruit the lung by vital capacity maneuver, which to be followed by PIP, and prevention of VD can be done by lung protective ventilation. So head-up position, vital capacity maneuver, manual, you can do it by keeping the APL valve closed at 40, keeping the FiO2 to 40, increasing the flow to 15 liters per minute, in a manual responsive mode and continue it for the 8 to 15 seconds. That will deliver the recruitment. Another way out to recruit the lung is the pressure control ventilation. Change the frequency to 4, change the air ratio to 1:1, increase the decrease the aperture to 40%. This will recruit the lung in 7.5 seconds. And it should be always followed by T. And you should apply direct pressure concept to ventilate the lung and use the lung protective ventilation even during the perioperative period. So these are the few publications through which I have taken the data. And at last, tribute to Dr. Patwa, who was my beloved teacher, and he has touched many lives during his journey to the earth, and he passed away last week. He was my beloved teacher. Thank you.
Apex, I have one question in this part. Can we do application of it just after extubation in OT? Because pre-operative we do it.
Yeah. So what you can do, after extubating a patient, you can apply CTEP of 8 to 10 if your machine is having a CTEP mode.
Thank you, Dr. Rich.
Sir, what modification one can do when we are thinking of restrictive lung disease or obstructive lung disease?
That's very important question because you need to make a tailor-made approach for each patient for recruiting the lung. That's very important.
If you can guide in short that which parameter can be altered.
Yes. Anything?
Thank you, sir.
Thank you, Dr. Rich. Before the Apex sir felicitation, I would like to introduce Dr. Bharat Shah, who is sitting as a chairperson here. He is a director and professor of anesthesiology at Vivekananda Medical College and Research Center. And I know sir was an ex-dean of DJMC Ahmedabad. So sir has got many things to even introduce, but sir please welcome. And I would like to call